My presentation today is going to be on tone management, specifically looking into spasticity and rigidity. We're going to review the physiology behind both and then what we can do as physical therapists to manage these symptoms. So first, what is muscle tone? Muscle tone is a relaxed muscle's resistance to both passive stretch and tension. And it is a combination of both passive and active components. Those passive components being non-contractile viscoelastic structures, such as actin, myosin, connective tissue, whereas the active component of muscle tone is that actual activation of contractile motor units, and it is detected via EMG. This is typically controlled by spinal and supraspinal mechanisms. Intrafusal fibers are the muscle spindle. They are sensory organs that detect changes in length and velocity. The extrafusal fibers are the muscle belly, and that contraction creates force and movement of that muscle. And just to review, tendon connects muscle to bone. So there's a couple different types of intrafusal fibers. There's two main types, being the nuclear bag and nuclear chain. They're named that way because all the nuclei are arranged in little bags for the nuclear bags over here. And then the nuclear chains, the nuclei are all arranged in like a chain form. But the nuclear bags detect changes in length and velocity of the muscle, and they send that information via 1A afferents back to the spinal cord. The nuclear chain fibers, on the other hand, detect changes in length of a muscle and send that information back to the spinal cord with 1A and 2 afferents. Both of these synapse onto gamma motor neurons in the spinal cord. Extrafusal fibers, on the other hand, they are the ones that contract the muscle itself, like we said, but are activated by alpha motor neurons from the spinal cord. So, to simplify the stretch reflex, the muscle stretches, sensory info is then sent back to the spinal cord, and the muscle contracts to prevent any overstretch damage. And to incorporate our knowledge of intrafusal and extrafusal fibers, we'll say the muscle stretches. The intrafusal fibers, so those sensory organs, sense that stretch, that change in velocity and speed, change in velocity and length, and then they send that information via 1A and 2 afferents back to the spinal cord, where there are synapses onto the agonist alpha motor efferents, which then cause that muscle contraction to prevent the overstretching. So, what is reciprocal inhibition? So, within the spinal cord, those 1A and 2 afferents also synapse onto inhibitory interneurons of alpha motor neurons. So, this inhibits alpha motor neurons of the antagonist muscles to contract while the agonist contracts. So, this result is just the antagonist muscle can't contract, so there isn't any further stretch of the agonist during an overstretch. A very good example of this is the patellar or knee reflex arc. So once that hammer hits the patellar tendon, the quadriceps muscle will have a quick stretch. The intrafusal fibers of that muscle will sense that stretch, send information back to the spinal cord via those 1A and 2 afferents, where they will synapse onto those motor neurons, which causes the quad to contract. Now, at the same time, they're also synapsing onto the inhibitory interneurons of the hamstring muscle, which does not allow the hamstring muscle to contract while the quad is contracting. So it relaxes the hamstring muscle. So, since the body needs to maintain a stretch sensation when a muscle is contracting, there is something called alpha gamma coactivation, and that occurs when the muscle contracts, both the extrafusal and intrafusal fibers contract, not just one. And this just allows that muscle spindle tension so that intrafusal fiber tension is maintained due to that contraction. This allows the firing rate of type 1A fibers and keeps it in an optimal range for detecting a change in muscle length, even while it's contracted. So, to put it all together, when a muscle stretches, intrafusal fibers sense that stretch, send information back to the spinal cord via the 1A and 2 afferents. There are synapses onto the agonist alpha motor efferents, causing that contraction of the agonist muscle. And there are also synapses on inhibitory interneurons to the antagonist muscle, so preventing the contraction of, let's say, the hamstring during a patellar tendon reflex. So there are also synapses onto agonist gamma motor efferents, which stimulates the agonist intrafusal fiber contraction. So it tensions that muscle spindle, maintaining that stretch sensitization. There are also synapses onto the inhibitory interneurons of the antagonist gamma motor efferents. So this inhibits the gamma motor neurons to the antagonist muscle, which actually desensitizes the antagonist muscle spindle to that stretch. So during the patellar tendon reflex, when the quad is contracting, hamstrings are going to lengthen a little bit, right? But in this case, because of these inhibitory interneurons, the muscle spindle isn't going to be super sensitive to that stretch. It's going to be more desensitized, allowing that hamstring muscle to lengthen. All right, so we're going to move on. Golgi tendon organs prevent tendon avulsion. On the other hand, they are located within the tendon. They're sensory organs similar to intrafusal fibers, right? They send information back to the spinal cord via 1B afferents. And one example of this would be when you're bicep curling just too much weight. So with that muscle contraction, the tendon at the muscle to bone junction, the tendon lengthens. GTOs are proprioceptive and sense length. So they send that information back to the spinal cord like, hey, I'm being stretched via the 1B afferents. In the spinal cord, there's synapses onto two interneurons, one being an inhibitory interneuron that is activated and inhibits the alpha motor neuron to the bicep, which decreases tension of the agonist, allowing that bicep to immediately relax. There's also a synapse onto an excitatory interneuron of the antagonist. So in this case, with the bicep curling too much weight, the triceps would actually be excited to pull the forearm in the opposite direction, just preventing any tendon avulsion, right? So those are two things that are happening and that the GTOs are responsible for. So we're going to get into some supraspinal influences. So we're going to go over the cortical spinal tract, which starts in the cerebral cortex, crosses at the pyramidal decussation, and then goes to the motor neurons. We're going to say for the purpose of this lecture, it inhibits lower motor neurons. That's the net effect. Now, on the way down, the CST also gives off the cortico-reticular pathway, which goes to the medullary reticulospinal nuclei and becomes the reticulospinal tract. Now, this inhibits lower motor neurons as well. Many different pathways are involved in muscle tone. We are just going to focus on those for this lecture. So where does it all go wrong? Where does hypertonia come into play and hyperreflexia come into play? So if there is damage in the cerebrum, there is inhibition of the reticulospinal tract, of the corticospinal tract, which causes a disinhibition, so excitation of motor neurons. So there's an increase in alpha motor excitation, which increases extrafusal fiber contraction, causing hypertonia. Now, because of this damage, this also increases gamma motor excitation. And what do gamma motor neurons do? They cause intrafusal fibers to contract and sensitize intrafusal fibers, which will be super sensitive to any type of a stretch, right? And so a reflex pathway is very easily activated in this case with just a small stretch, causing hyperreflexia. So many pathways are involved. Medullary reticulospinal tract has a super large effect on hypertonia and hyperreflexia. And studies even show that later on, the reticulospinal tract may even take over more muscle movement to make up for a dysfunctional cortical spinal tract and spasticity. So we're going to differentiate spasticity versus rigidity. So spasticity is velocity dependent, whereas rigidity is not. So no matter how quick you move that limb, rigidity is going to do the same thing, whereas spasticity might do different things. Spasticity is often resistant in one direction, either flexion of a joint or extension, whereas rigidity is often resistant in both directions. Spasticity is length dependent, whereas rigidity is not. And then there's a couple different types of hypertonicity. With spasticity, you often see a clasp knife effect, which we'll get into later. And in rigidity, you can see lead pipe or cogwheeling, which we will also discuss. So what is the clasp knife effect? Basically, when there is a high velocity, quick stretch, so a very quick movement of a muscle or joint, the nuclear bag, which is a type of intrafusal fiber, sends 1A afferents to the spinal cord, which causes a sudden contraction of that muscle. Further into the stretch is detected by nuclear bag and nuclear chain, so types of intrafusal fibers again, sending information back to the spinal cord, activating those alpha motor neurons, causing a contraction to maintain the resistance through part of that range. The release that we see with spasticity in this clasp knife effect is when the Golgi tendon organs, so the 1B afferents, activate, which inhibits alpha motor neurons, reducing resistance and allowing some stretch to take place. So this would be like a Tardieu type 2. Seen down here, there's a clear catch when you move that muscle through a range of motion at a precise angle, and then the Golgi tendon organ allows that release, so that relaxation of that muscle to prevent tendon avulsion. So that kind of puts all of our knowledge together right there. Now, why are only some muscles spastic? The simple answer is that they're just more excitable to begin with. Both biceps, plantar flexors are very excitable and just used throughout our daily life. So that excitability is amplified after injury. How we reviewed that the RST and CST are hyperexcitable, they're disinhibited. So, because they're used throughout our daily life, they're just more excitable to begin with, and they're more often our spastic muscles. Now, why do we have synergies? Synergies occur because our body wants to compensate for any errors. So, if one muscle is weak, we're going to use other muscles around it to help achieve that same or similar motion. It's also for energy efficiency. So our central nervous system reduces the complexity of movement by organizing muscles into synergies, allowing for very quick automatic movements without any higher level control. Our upper extremities are often flexor synergy dominant, and our lower extremities are often extensor synergy dominant. And here's some pictures of those right there. This is a flexor synergy of the upper extremity. This is our extensor synergy of our upper extremity. So after an upper motor neuron lesion, when the corticospinal tract is damaged, the body increases reliance on the reticulospinal tract, which is, as we said, less capable of fine motor control and better at gross motor control, leading to these synergistic movements. The reticulospinal tract is excited, causing that involuntary co-contraction where you try to lift your shoulder and your elbow and wrist flex along with it. Just to review, manual muscle tests for physical therapists are not indicated for synergistic muscles because they're widely inaccurate. Co-activation of other muscles makes it very impossible to isolate one muscle. And also, it's not really purely volitional movement, but rather more automatic reticulospinal tract driven. So instead, you should use a different staging system like post-stroke. The Brunstrom staging can be very useful where you're saying, oh, spasticity is beginning, synergies are beginning, there's movement outside of synergy. You can describe what you're seeing with that as opposed to manual muscle tests. So there are many benefits of spasticity. It's not always bad and not always something we need to manage medically. It can actually improve functional activities like transfers, standing, and gripping. And acute increases can also be a sign of something awry in the body. So our body's way of saying something's wrong, if there's like a UTI, fracture, pressure sore. It can also improve venous return and circulation with those muscle contractions. It can protect against deep vein thromboses, reduce fracture risk, reduce risk of osteoporosis, protects against muscle atrophy, and can be a marker of motor recovery potential, especially in those after stroke. Now we're going to move on to Parkinson's disease and rigidity, as this is a common diagnosis associated with rigidity. Rigidity is an increased resistance to passive movement affecting both the flexor and extensor muscles in Parkinson's disease. The neural mechanisms are very complicated and very incompletely understood. There are two main types of rigidity. There's cogwheeling, where there's this ratchet-like motion through a range of motion. And it's thought to be due to rigidity with an underlying tremor or a tremor that's present. EMG studies show phasic bursts of muscle activity, whereas with lead pipe, there's a more tonic increase in muscle tone and there's a smooth, consistent rigidity through a range of motion. With the different pathways involved in Parkinson's disease, we'll review both of them. There's something called the direct pathway, normally facilitating movement by disinhibiting, so exciting the motor cortex. Then there's your indirect pathway, which inhibits movement in the brain. It becomes overactive due to a lack of dopamine in Parkinson's. There's increased inhibition of the motor cortex, which decreases activation of the CST, particularly the spinal tract, causes increased activation of those alpha motor neurons, leading to rigidity and bradykinesia. So the increased inhibitory output from the basal ganglia leads to excessive excitation of alpha motor neurons, causing sustained muscle contraction and rigidity. There are many other mechanisms involved that researchers are still understanding. So feel free to research this in your own time. It's something that researchers are still looking into, and there's many different articles coming out about this every day. But for now, we're going to focus on the American Academy of Physical Medicine and Rehab consensus guidelines for spasticity management. Our first grading is on SDR, selective dorsal rhizotomy. This is graded an A in this systematic review. So what is SDR? It is an irreversible surgery where sensory neurons are cut, preventing that stretch reflex that we talked about from contributing to spasticity. It's primarily used for children from 4 to 10 years old and a few adults who are unresponsive to other treatments, primarily with those who have cerebral palsy. It's typically indicated for diffuse spasticity and decreases spasticity as far as 17 years post-surgery. After SDR, early intense PT is indicated to just capitalize on those opportunities to change motor patterning. But you do want to monitor for dysesthesias, and gabapentin can be given if these are experienced and usually lasts a couple of weeks. With tendon lengthening, this occurs when you cut part or all of the tendon to lengthen it during a surgery. So typically this is indicated for cerebral palsy kids, but sometimes also in spinal cord injury, stroke, and DMD, but all options must be trialed prior. For Achilles lengthening in particular, it's indicated with severe contracture. So doctors are typically looking for about 20 degrees of plantar flexion or more. Afterwards, they have to cast the area for 6 to 12 weeks and use crutches for 4 to 6 weeks. Intensive physical therapy is indicated with stretching, strengthening, non-articulating AFOs. However, there is a risk for over-lengthening the Achilles, which, as we all know, worsens gait and causes poor power off or poor power and toe off and a risk of crouching in mid-stance. So the next one we're going to go over is neurotomies. Neurotomies include cutting the peripheral motor nerve. So to review the SDR surgery that we went over, cuts the sensory nerve. The neurotomy cuts the peripheral motor nerve. This diminishes that reflex arc, reducing spasticity. And it's mainly used for focal spasticity. So just like a couple muscles, one or two in that area. So it's very specific. The modified Ashworth scale, which is a measure for muscle tone, is typically above 3, just indicating that passive movement is very difficult for that person to achieve. And it's indicated after Botox is trialed and failed or is just too costly. Now, neurotomies have a pretty big success rate for decreasing spasticity, about 80 to 85%. However, this procedure can induce paralysis or decrease strength, but the patient can recover the strength via other motor nerves, helping to compensate. Now, Botox is rated an A for focal upper and lower limb spasticity. So, like we said, it's typically for one or two muscles. It's very focal relief, so very specific relief. It inhibits the release of acetylcholine at the synapse over here. So, messing with these snare complexes to form at the synaptic terminal. And it's been shown to increase or to improve modified Ashworth scores, so that marker of muscle tone. And its effects last about 3 to 4 months, with its peak effect being about 3 to 4 weeks post-injection. So after Botox, you can use AFOs or orthoses post-procedure to further improve gait. Um, it can also decrease pain due to spasticity. So Botox can be a pain reliever as well. Problems include that it is expensive, not always covered by insurance, and some adverse local effects can include weakness, pain, leg cramps, and rash. And very occasionally, in those that are really getting recurrent doses of Botox, there can be systemic effects documented, such as dysphagia, dysphonia, dyspnea, respiratory distress. Now, this was a picture that one of my professors showed me in physical therapy school, basically demonstrating increase in fatty infiltrate post-Botox. So this is the control prior to any Botox injections. Over here, you have what a muscle looks like after one dose of Botox. Over here, you have after two. Over here, you have after three. Now, post-Botox, it's been shown in animal and human studies to decrease muscle size and increase fatty infiltration. In animals, there's been evidence to show that this also reduces muscle strength in adjacent and contralateral non-target muscles, which is super interesting. In humans, it's been shown that a single dose of Botox can reduce muscle size for up to 1 year and even decrease strength up to 50%. So, my Botox takeaway is to weigh benefits of decreasing spasticity to cons of decreasing strength when making recommendations. You really want to emphasize strengthening prior and after Botox because of this reason. And at the 3 to 4 week mark after they receive a Botox injection, you want to capitalize on motor patterning, as this is when peak effects occur. We want to keep in mind that Botox can be beneficial for decreasing pain, and you want to monitor for systemic muscle weakness in those getting recurrent Botox injections or very high doses. Now, phenyl alcohol blocks are similar to Botox, where you're targeting a very focal muscle, right? However, it is rated a C on these guidelines. Now, phenyl alcohol blocks include an injection into motor nerves, immediately ceasing contractions and spasticity. That chemical denatures protein, resulting in a neuropraxic injury or denervation. And the average duration of effects is a lot longer than Botox, so about 3 to 9 months. However, it is usually a treatment of last resort, as there are inferior effects compared to Botox. And there's also a risk for very painful adverse effects, including phenol spreading to sensory nerves, causing dysesthesias that range between 10 to 30%, depending on the study. So, next we're going to go over oral medications. Oral medications are typically for systemic spasticity, not focal, and they are rated a score of a C. So, baclofen is our most common muscle relaxant. It's a very common drug used for spasticity. However, there is some caution to use this with cerebral forms of spasticity just due to the interference with attention and memory on brain-injured patients. It is a GABA B agonist, so it acts at the spinal level to inhibit excitation of those alpha motor neurons that we talked about. So we talked about how in spasticity there's overexcitation. GABA B agonist kind of acts to decrease that excitation at the spinal level. So, baclofen's peak concentrations occur about 2 to 3 hours after ingestion, and it's often taken in smaller doses throughout the day. It has a short half-life of about 2 to 6 hours. Our patients do complain of many adverse effects, the most common being like sedation and drowsiness. However, it can also cause dizziness, constipation, confusion, hypotonia, ataxia, to name a few. And sudden withdrawal can cause seizures and hallucinations. So you really want to be cautious about stopping this suddenly and educate your patients to not stop without a doctor's advice on how to wean off of baclofen. Now, baclofen pumps, on the other hand, are rated an A. And the baclofen pump is inserted via surgery where the pump is implanted under the skin of the abdomen, and then the catheter is threaded from the pump to the spinal fluid in the low back, bypassing the blood-brain barrier. This allows for a continuous delivery of baclofen and lower doses compared to oral administration. You need to trial oral baclofen prior to getting this, just to check for different side effects and see if the patient can tolerate that well. And there's a couple of contraindications, just like local infection in the area, and another common one is just insufficient body mass for the pump bulk. It's indicated for those with severe spasticity, often when oral medications fail. And there is advice to wait at least 1 year or more after brain or spinal cord injury before consideration. It's typically indicated for those with global or regional spasticity, those who have cerebral palsy, brain injury, stroke, spinal cord injury, or MS. And similar to baclofen, the medication, there are a couple of negative effects on arousal and cognition. Most medications will last about 2 to 3 months before requiring refill, and the batteries last about 4 to 7 years. You need a full another surgery to replace that battery. Going back to medications, again, to remind you, rated a C on the systematic review, the consensus guidelines for PM&R physicians. Tizanidine is the next one we're going to go over. Basically, this is an alpha-2 adrenergic agonist that causes a decrease in presynaptic activity of these excitatory interneurons in the spinal cord. This also decreases the stretch reflex activity and motor neuron excitability, and often used in both spinal and cerebral disorders like MS, stroke, and ALS. Similar to baclofen, it causes sedation, dizziness. Dry mouth is another symptom that commonly occurs, but weakness is not as big of a problem. Lasts about 3 to 6 hours, with max effects around 1 to 2 hours after administration, and has been shown to have a more favorable tolerability profile. So there's less muscle weakness, less sedation compared to baclofen. So if someone is really not tolerating baclofen well and does not like the sedation effects, this is sometimes a medication that's used alternatively. Dantrolene is one that acts outside of the central nervous system. It actually acts at the muscle fiber level. It inhibits the release of calcium from the endoplasmic reticulum in muscle cells. And as we know, calcium normally binds onto troponin and actin filaments, allowing for that actin-myosin cross-bridging. So by inhibiting this release, you're inhibiting the contractility of muscles. Peak effects occur 1 to 3.5 hours after ingestion, and it is pretty long-lasting, lasting about 8 to 10 hours. Some side effects include weakness, sedation, GI symptoms, big warnings for serious hepatotoxicity, which requires liver monitoring before and after. And there's a big contraindication for ALS patients. So you do not want to use it in ALS patients as it can progress muscle weakness as it acts at that muscle level. It's also less sedative than baclofen, so there's more preserved cognitive function, and this is why this is also used with spasticity. There's also diazepam, another medication. It's a GABA A agonist acting on the brain and spinal cord. Typically very short term, very quick onset of action, 15 to 60 minutes. Duration lasting about 12 or more hours, super long lasting. Certain side effects include sedation, impaired memory, ataxia, fatigue, bradycardia, hypotension, as well as some others. However, it is a Schedule 4 controlled substance with the potential for abuse. Abrupt cessation can cause seizures and hallucinations. And you typically just don't recommend it for elderly patients with decreased renal function due to issues with diazepam accumulation and renal issues. So, oral medications, when would you recommend them? The consensus guidelines agree that if there is pain or interference with ADLs or physical therapy, they're a good choice. They're typically not recommended for focal spasticity due to the global effects of the drugs. And if spasticity does help with walking or functional tasks, you obviously don't want to recommend it if it's actually helpful. Like we mentioned, there's a lot of pros of spasticity, so you just want to weigh that when making this decision. With oral medications, we did talk about the adverse effect on cognition and sedation, so you really want to educate patients about these risks before suggesting drugs or suggesting that they go to their doctor and ask about them. In many stroke patients, spasticity is local, as well as in other diagnoses, very local, so that's easily targeted with other means like Botox or peripheral nerve blocks, not necessarily systemic oral medications. So that's just good to keep in mind. All right, so non-farm, this is where we come in as physical therapists. So this American Academy of Physical Medicine and Rehab did not grade this just due to limitations in evidence. So we're just going to go over the couple of articles that are out there regarding non-pharmacological mechanisms to decrease spasticity. The first being neuromuscular electrical stimulation, or NMES. There's one really big SR and meta-analysis by Stein et al. In 2015 that showed decreases in spasticity and increases in range of motion when compared to controls. Most often, NMES is used on the tibialis anterior or the gastroc in combination with gait training, which both show improvements in tone and stiffness, with the tib ant showing slightly better improvements in gait and spasticity. Now, the tib ant is based on that theory of reciprocal inhibition that we talked about, where if one muscle is contracting, the other one has to relax. So it makes sense that with the gastrocs that are typically spastic, if we activate our tib ant and cause that muscle contraction, the gastrocs are going to want to relax, or the gastroc and soleus complex. Typically, NMES has only been shown to decrease spasticity short term and when in use to up to about 15 minutes after use. So spasticity can lead to weakness, which necessitates strength training due to relative immobilization or chronic disuse. There's that shift to type 1 fibers from type 2. This further causes plastic rearrangements in higher centers that reduces the ability to voluntarily recruit motor units, which can aggravate spasticity. So strength training is inconclusive to decrease spasticity, but it is important to keep in mind to train to minimize atrophy and improve motor control. Now, some physical therapists like to strengthen the antagonist just to decrease the spasticity of the agonist. And this is thought to help via reciprocal inhibition. So like we said, when one muscle contracts, the other stretches and relaxes. This is just used in theory. There is no direct evidence that I have found via PubMed for decreases in MAS or any other ways to measure spasticity. So this is just based on theory, but some have been shown to decrease spasticity with strengthening the antagonist muscle. With weight bearing typically provides proprioceptive input. It activates a lot of different things like joint mechanoreceptors, cutaneous receptors. It also activates spinal interneurons, which decrease motor neuron excitability, which is great. That's exactly what we want. A 2004 study showed that it decreased motor neuron excitability to the soleus, allowing higher reflex thresholds to allow for walking. And because we know spasticity increases that motor neuron excitability, this is great. This is also why our patellar tendon reflex is just not as intense in standing, right? So if someone were to hit that patellar tendon, you're not going to kick out quite as much as if you were just sitting with your feet dangling. So this weight bearing just increases afferent input and reduces that hyperactive stretch reflex. There's many different ways to increase weight bearings, but most studies focus on body weight treadmill training, kneeling walking, even to show a decrease in modified Ashworth scores and spasticity and stretch reflex. Now, whole body vibration's another one that we use in the clinic. The mechanism of whole body vibration therapy has not been fully proven, but it's been proposed to activate those 1A and 2 afferent fibers we were talking about, just increasing that sensory input to the central nervous system, thought to cause some type of presynaptic inhibition, decreasing that motor neuron excitability. Studies have shown that it reduces that reflex activity by modulating spinal excitability, enhancing voluntary selective muscle activation. Um, so with spasticity, the muscle does overreact to a small stretch. So by reducing that reflex activity, the patient can access voluntary muscle activation supraspinally better. Now with casting, casting is something a doctor can do in which a sequence of casts are applied progressively over greater ranges of motion from several weeks to months to increase range of motion. Basically, you want to find the maximal stretch of that muscle, cast it, and then the muscle will fatigue and elongate with that. Cast is typically changed every 2 weeks to a new lengthened position. And after Botox, casting actually has been shown to facilitate further spasticity reduction. There's very mixed evidence here, but it seems that with post-stroke, there's level C evidence for mild to moderate elbow and wrist contractures. Children with CP show some decreased modified Ashworth scale scores, so decreased spasticity scores, increased range of motion, and improved gait. And then for TBI, there's actually grade B evidence to improve passive range of motion and prevent the loss of range of motion. So not necessarily improving spasticity, but just improving that range of motion. Next, we're just going to go over the cons of serial casting. Some cons include atrophy, skin breakdown, pain, discomfort, and can really affect your activities of daily living and gait. When you have a big cast on, makes it harder to lift that leg or lift that arm. So you really want to weigh all of these when suggesting this to your patient. AFOs are next, ankle foot orthoses. They've been shown to decrease or prevent contracture, increase dorsiflexion, range of motion, improve the gait mechanics, speed, and also improve spasticity via a decreased stretch reflex and improved modified Ashworth scale score. This is what they look like. One example. Night splints. This has very little evidence to support besides a combination with Botox and this. There's been shown to be best effects on spasticity there, but alone there's very mixed or little evidence with different studies saying that there's strong evidence that there is no reduction in spasticity or contracture with wrists and ankles, even if they're wearing it 12 plus hours a day, which is super interesting. With aerobic activity, specifically high intensity activity, this increases brain-derived neurotrophic factor, BDNF, which has so many great effects, dopamine, just improving neuroplasticity, retention learning, decreasing neurodegeneration, mood, but it also changes cortical inhibition and decreases motor neuron excitability. So it's just allowing us to decrease spasticity acutely, especially shown in those with stroke. This is one picture from an article that shows that with one arm, so just like let's say using the left arm, cycling at about 50% max workload for 10 minutes, um, there's actually spasticity reductions in the opposite arm. So there's a systemic effect of aerobic activity in decreasing spasticity. There's also been shown through rodent models to decrease spasticity through BDNF, which is released during aerobic activity, modulating that excitability, so decreasing that motor neuron excitability in the spine. Now, stretching. There is not a lot of evidence to support it as a long-term spasticity management. There's a lot of studies that show maybe short-term decreases in spasticity, not long-term. And typically it's not to statistically significant levels. Um, there's very mixed results on if this even affects motor neuron excitability. So there's no harm in doing it. It doesn't hurt you, right? And you might get some small short-term effects if you want to try that before a functional exercise or before something else functional. But it's really just there to prevent contractures and decrease pain. Um, and even that, there's no conclusive evidence to support that. Cryotherapy is another thing that we can use in the physical therapy clinic. This has been shown to decrease nerve conduction velocity, decrease an H to M ratio, which is just a measure of that stretch reflex that we talked about. Multiple studies show a decrease in spasticity post-icing, with most recommending about 20 minutes of icing to decrease spasticity for around 30 minutes, and without an effect on proprioception or muscle torque capacity. Thermotherapy, on the other hand, there was one person in particular, Matsumoto, who wrote articles about this in 2006, 2010, and 2014, showing that a warm foot bath can decrease muscle tone for as long as 30 minutes after a 10-minute bath, just by dampening muscle excitability. So this is another alternative to decrease spasticity prior to something like gait training. Aquatic therapy in warm water can also decrease spasticity, which has been shown in one study by Kezikatas in 2004. Going back to rigidity, so our other muscle tone type that we were talking about, specifically in Parkinson's disease, they have also shown in articles that stretches have low quality evidence to support a decrease in rigidity. Many studies show maybe a slight decrease, but typically not to significant levels, whereas aerobic activity, very high quality evidence, especially with forced aerobic activity in the clinic, showing improved UPDRS-3 scores, which is a huge way to measure Parkinson's disease severity, specifically improving those scores in the rigidity portion. Whole body vibration therapy has also been shown to improve rigidity scores in randomized controlled trials, specifically looking at that 6 hertz with an amplitude of 3 mm. With Botox, there's also a slight decrease in rigidity scores based on a couple of RCTs. However, I've not seen that too often in the clinic. With pharma, so things like Cinnamate, there's a big effect on rigidity, and there's very high quality evidence to support its use for decreasing rigidity in Parkinson's. Deep brain stimulation is also another surgical treatment to decrease rigidity and other motor symptoms and symptoms in general in Parkinson's disease. Basically, it uses electrical stimulation of brain areas, and it's typically indicated for those with intense symptoms during off periods with their meds, often used for those that experience very intense dystonia, rigidity, and tremors. And it's typically not used for those with imbalance issues, memory problems, or those who are older just because of the surgery and the brain areas that you have to go through. You would expect lower med dosages, shorter off periods, and reduced rigidity with this surgery if it were successful. So my recommendations for the treatment of spasticity and rigidity, hypertonia, is just to test, retest. Especially us as physical therapists, we want to use scores like the modified Ashworth scale or TARDU to quickly assess if our intervention is making a difference or not for this patient. TARDU tests at different velocities, and since spasticity is velocity dependent, you may not pick up on spasticity as well as if you use the TARDU table. Future interventions, there are many interventions coming out, including different types of electrical stimulation, both around the spinal cord and in the spinal cord. There's things like transcranial direct current stimulation, transcranial magnetic stimulation, all of which have been shown to be promising in a different area of research, trying to contribute to spasticity and tone reduction. So in summary, the more common types of hypertonia that we see in the physical therapy clinic are rigidity and spasticity, with stroke and spinal cord injury causing spasticity due to that loss of inhibition from the CST and RST, causing that overexcitation of motor neurons. With Parkinson's, we often see rigidity due to that basal ganglia degeneration. Many physical therapy treatments out there for reducing spasticity and rigidity. But again, like I said, it's very important to test and retest with the modified Ashworth or TARDU scales. So thank you for coming to my lecture, and here are all of my citations that I used.